बिस्मिल्लाहिर्रहमानिर्रहीम। मैं सब लोगों को खुशामदीद कहता हूं और सबसे पहले आप लोगों को रमज़ान की बहुत बहुत मुबारकबाद देता हूं। अल्लाह ताला से दुआ है कि अल्लाह ताला आपको रमज़ान के बाबरकत महीने में अल्लाह ताला से नेकियां कमाने की आपको अल्लाह ताला तौफीक दे। अल्लाह ताला अपने गुनाहों की माफ़ी मांगने की तौफीक दे। और जितने मरहूमीन हमारे हैं और कुछ हमारे कोविड दौर में हमारे डॉक्टर हजरात जो फौत हो गए हैं, उन सब के लिए अल्लाह ताला से दुआ करे, अल्लाह ताला उनको जन्नतुल फिरदौस में जगह दे और हम सब लोगों को अल्लाह ताला सेहत की दौलत दे और दुनिया और आखिरत की खुशियां अता करे। आपको पता है कि थॉरेक्स जो है लीडिंग जर्नल है दुनिया का इन रेस्पिरेटरी मेडिसिन, एंड एवरी मंथ वी मीट फर्स्ट ट्यूसडे ऑफ एवरी मंथ. We choose an article from Thorax, which is a part of the BMJ group, through the courtesy of KZ Pharmaceutical, and we discuss 2 articles in every month. And not only people join on Zoom link, but people also join at their respective hospitals, and average attendance of this BMJ Journal Club is around 400 to 500 in the past 1 year. So today we have 2 very distinguished speaker. One speaker is a great friend, Dr. Azam Mushtaq from Multan, and another is our Dr. Mujahid, who works at Indore Hospital. So without any further ado, I will just request Dr. Azam Mushtaq. Azam Mushtaq is the head of the Department of Pulmonology at the Qaid Azam Medical College, Bahawalpur, Victoria Hospital, Bahawalpur. And he is well known in Pakistan Chest Society, and he has major contribution as examiner in FCPS, as well as a supervisor. Many of his training are now working as consultant and as assistant professor in various parts of Pakistan. So I request Dr. Azam Mushtaq, can you start with your first paper, please?
Bismillahirrahmanirrahim. Greetings of this holy month of Ramadan from my side as well, and I request my share of a prayer, my share in your prayers. Thank you very much, Professor Javaid Khan Sahab, for such a good introduction of mine. And this was the disclaimer as ever. I have chosen a very interesting topic, that lung transplantation for acute exacerbation of interstitial lung disease. Normally, you see, we always prefer in any disease, we say let it stabilize first, and then we will go for any operation. But here, there is paucity of this studies in this topic, that here the idea is when the patient has got acute exacerbation, of course, not directly after stabilizing a bit, he can be sent directly for lung transplantation or not. So we will discuss in the coming 15 minutes or so, and you will find it very interesting. As Professor has already introduced me, I'm working as a head of pulmonology department, Bahawal Victoria Hospital, Azam Medical College at Bahawalpur for the last 3 years now. Interstitial lung disease, it comprises a group of parenchymal lung diseases which are characterized by histopathologically by chronic inflammation and fibrosis. And due to heterogeneous nature of these diseases, so many diseases come in a single group, means IPF, then chronic hypersensitive pneumonitis and connective tissue disorders, related ILDs, and acute or chronic interstitial pneumonias. So it was the clinical course of the patient is very much variable and maybe unpredictable. Acute exacerbation of interstitial lung disease, as you know, AEILD, have a high mortality rate with no effective medical therapies except for high dose steroids, which now the authorities are saying that maybe even causing worse effects, and some antibiotics and supportive. Lung transplantation per se is a potentially life-saving option for patients with AEILD, but its role is not well established. So the aim of this study is to determine if this therapy during AEILD significantly affects post-transplant outcomes in comparison to those transplanted with stable disease. And previously also there are some studies of transplant in during acute exacerbation, but those were only limited to IPF. But here it is generally discussed in terms of ILDs. इसमें जिसमें के जो पहले मैंने डिस्कस की डिजीजेज वो भी शामिल हैं. But mainly again in that group was IPF, chronic hypersensitivity pneumonitis, and connective tissue ILDs. As you know, the annual incidence of AEILD is 7 to 20% per patient, meaning by the every patient in a year time will get 70 or 20% chances of getting ILD, acute exacerbations. In hospital mortality for AEILD patients ranges from 30 to 50%, and it can be as high as 90% in those requiring mechanical ventilatory support, because lung is stiff and it is very difficult to wean off these patients from the ventilator. So when you put them on ventilator, mechanical ventilation, there are 90% chances of mortality. Post-hospitalization survival is also impacted, with survivors having a median survival time of 2.2 months only. So the largest study to date reported a substantially higher mortality after transplantation in patients with AE-IPF as compared with stable IPF, with significantly reduced 1 year and 3 year survival. But again, I will stress that it was only IPF. Among ILDs, IPF, जिसमें histopathologically आपको जो यूजुअल इंटरस्टिशियल pneumonitis पैटर्न मिलता है फाइब्रोसिस में, तो उसमें ये स्टडी हुई थी और वो भी उसमें उसके इतने अच्छे रिजल्ट्स नहीं थे ऑफ AEIPF as compared to with stable IPF patients as far as transplant is concerned. This study was conducted a retrospective study of consecutive patients. It was not a multi-center, it was a unicentral trial. It was a single center of Florida University of consecutive patient with AE-ILD admitted to our institution from 2015 to 2018. And to give every patient a 1 year survival, the study up to March 31, from 31st March 2020, ताकि सबका 1 साल का सर्वाइवल भी पूरा हो जाए, क्योंकि आगे मैं बताऊंगा कि इन्होंने 1 year सर्वाइवल भी देखा है. The comparison group included patient with stable. आधों को इन्होंने जो of course जो नहीं ट्रांसप्लांट के लिए जा सकते थे उनको इन्होंने मेडिकल ग्रुप में रखा, और जो ट्रांसप्लांट के लिए जा सकते थे acute exacerbation वाले उनको इन्होंने ट्रांसप्लांट ग्रुप में रखा with ethical committee, with the permission of the ethical committee, of course. The primary endpoints were in hospital mortality for patients admitted with ILD and 1 year survival for the transplanted patients. So the results were interesting. Standard care for lung transplant recipients was given to every patient, which was Bacillimixab 20 milligram on the day of transplantation and at the post day 4, and also every patient was given triple drug immunosuppressive regime like prednisolone, tacrolimus, and mycophenolate as for their standard protocol. And the doses were adjusted according to the trough levels. Primary graft dysfunction and acute cellular rejection were diagnosed and graded per International Society of Heart and Lung Transplant guidelines. इसमें तो ये था कि ये लोग biopsies लेते थे, इन्होंने after transplant biopsies ली on day 1 and after 24 hours, 72 hours फिर उन बायोप्सीज को तमाम डिफरेंट बायोप्सीज के साथ इन्होंने मल्टीप्लाई इन्होंने जो है सब्सट्रैक्ट करके जो फार्मूला था उसके मुताबिक ये लेवल इसका इन्होंने प्राइमरी ग्राफ्ट डिसफंक्शन एंड एक्यूट सेलुलर रिजेक्शन का फार्मूला है, उसके मुताबिक इन्होंने इसको ग्रेड किया। The date of acute rejection was defined as the date of biopsy, and time to acute rejection was calculated as the time from transplant to the first episode of acute rejection. The primary outcome of the study was survival till the discharge, and the secondary outcome in transplanted patients included incidence of post the primary graft dysfunction at 0 hours, 24 hours, 48 hours, 72 hours, as I already mentioned, after the transplantation, reintubation, rate of tracheostomy, cellular rejection. ये पूरा क्राइटेरियन है और इसका ये नहीं है। भारत इसमें बायोप्सीज इन्होंने ली और उस बायोप्सी में जो HLA जो acute transplant rejection है वो HLA mediated होती है और उसके अंदर जो certain criteria हिस्टोपैथोलॉजिकल सोसाइटी के बनाए हुए हैं उसके मुताबिक उन्होंने उसको लेबल करना था कि एक्यूट ट्रांसप्लांट एक्यूट सेलुलर रिजेक्शन है कि नहीं। और इसी तरह प्राइमरी ग्राफ्ट डिसफंक्शन भी एक सोसाइटी ने डिसाइड किया जिसमें हेमेटोलॉजिस्ट और दीगर पैथोलॉजिस्ट शामिल थे एंड ब्रोंकोस्कोपिस्ट और जो स्टैंडर्ड प्रोटोकॉल है उसको फॉलो किया गया। इट इज गिवन इन डिटेल इन द पेपर। Now, something about results. Of the 53 patients admitted for AEILD, 28 were treated with medical therapy alone and 25 underwent transplantation. So ये दो ग्रुप बनाए उसमें 28 थे जिनको मेडिकल थेरेपी दी जो कि फिट नहीं थे अदरवाइज ऑपरेशन के लिए, अदरवाइज तो फिर वो एथिकल ग्राउंड्स बन जाते हैं। तो ये उन्होंने पेशेंट ही वो सिलेक्ट किए जिनको जो अदरवाइज जिनमें इंडिकेशन नहीं थी फॉर लंग ट्रांसप्लांट के लिए। जो लंग ट्रांसप्लांट का क्राइटेरिया है वो मैं थोड़ा सा बताता चलूं कि हाई ग्रेटर देन 50% रिस्क ऑफ डेथ ड्यू टू लिवर लंग डिजीज विद इन 2 years of lung transplant if lung transplant is not performed, and high greater than 80% likelihood of survival at least 90 days after lung transplantation। अगर ये हो तो फिर वो कंसिडर करते हैं। and high greater than 80% limitation of greater than 80% likelihood of 5-year post-transplant survival from a general medical perspective। अगर ये चीजें हों तो फिर उसको हम acute exacerbation वाले को ट्रांसप्लांट के लिए भेजेंगे, इवन स्टेबल में भी। तो अगर ये क्राइटेरिया जो पूरा नहीं करते थे उनको उन्होंने रखा मेडिकल थेरेपी में एंड 28 were treated with medical therapy alone and 25 underwent transplantation. All patients with AEILD who underwent transplantation survived to hospital discharge, whereas only 43% of AEILD were medically treated. I will repeat, there was a problem. All patients with AEILD who underwent transplantation survived to hospital discharge, whereas only 43% of AEILD medically treated, they reached till the time of discharge. During the same period, 67 patients with stable ILD underwent transplantation. Survival, अब ये 3 ग्रुप बन गए, एक मेडिकली ट्रीटेड वाले AEILD वाले, दूसरा AEILD वाले which were transplanted, और 67% दोज जो स्टेबल थे और उनको भी ट्रांसप्लांट, वो ये पहले से उनकी लिस्ट में थे और बड़े स्टेबलाइज करके उन्होंने रखे हुए थे। Survival at 1 year for the transplanted patient was not different from the AEILD group versus stable ILD group, बल्कि significantly difference बल्कि जो थे AEILD वाले वो 96% में कुछ ज्यादा ही था बल्कि, लेकिन significantly कोई difference नहीं था। The rates of primary graft dysfunction, post-transplant hospital length of stay, and acute cellular rejection were similar between the groups. ये थोड़े से flow diagram है कि 120 for total 124 patients with diagnosis of interstitial lung disease, whether IPF भी इसमें included था, chronic HP, connective tissue disorders and others. General group of the 124, 55 patients with AEILD on hospital admission. Then on hospital admission में 28 patients received optimal medical treatment with high dose steroids, inhaled nitrous oxide, inhaled vasodilators and all, and for pulmonary hypertension treatment, which we give normally in our hospitals. And only 12 survived to the hospital discharge. Discharge का date जो थी वो मैंने पहले बता दी कि कहाँ से कहाँ तक. So 57% died in the conservative. Now in that 5 patient group, 27 patients listed for lung transplantation. इनमें से 16 जो थे वो लिस्ट थे पहले से पास to admission, and 11 patients were transplantation. 25 patients undergo lung transplantation, and 25, all of them, they survived to the hospital discharge. So 0% were deaths. So 25 patients were alive at 1 year follow-up, and 4% only died. In the 69 patients group with stable ILD, जो पहले से listed थे, जिनका plan था, we were stable. उनमें से 2 were delisted due to comorbidities and generalized उनकी condition deteriorate हो गई. 67 patients underwent lung transplantation, and 65 patients survived to hospital discharge. It means 3% died, and 62 patients were alive at the 1 year follow-up, which means 7.5 died. लेकिन significantly जो ये हमारे 2 group हैं, ये और ये, they were statistically not different, so which made this study. This is the graphic representation of the same. कि ऊपर ये survival है in percentage, और ये जो dotted group है ये AEILD वाला transplanted है, और नीचे जो बगैर dotted और ये hood वाला है जिसे stable ILD transplanted है, और ये time चल रहा है in hours, और ये 90 hours तक इन्होंने तकरीबन 84 hours बनते हैं, यहाँ तक इन्होंने ये जज किया, और ये comparable है. So patients with ILD transplanted during AEILD had no meaningful difference in overall survival, rate of primary graft dysfunction or acute rejection compared with those transplanted with the stable disease. And the results of the study of this center suggest that lung transplantation can be considered as a therapeutic option for selected patients with AEILD. जो otherwise criteria पूरा करते हैं और lung transplant का, उनमें AEILD वालों को भी we can refer for lung transplantation, or we at least we should know, we think that this patient can be transplanted successfully. Regarding discussion, there is a lot of discussion over this, because there were a lot of differences in the groups. जो studies पहले हुई IPF की, उनमें और इसमें कई differences थे. तो वो stable patients भी थे और खाली IPF के थे. दूसरा जो था difference वो ये है कि कुछ लोगों को high flow nasal cannula और HFNC और BiPAP, CPAP की हद तक non invasive ventilation पे रखा गया था, और कुछ को even जो है ventilation पे और ECMO के ऊपर रखा गया, और during operation even कुछ को ECMO पे रखा गया और कुछ को heart lung transplant machine पे रखा गया. So these were differences. और कुछ को जो है जो during operation, before operation and during operation, किसी को जो है वो steroids ज़्यादा दिए गए और किसी को जो है inhaled nitric oxide जो ज़्यादा दी गई. तो ये थोड़ी सी confounding चीजें. उसके अलावा ये थोड़ी सी discussion बनती है कि the current report is the first published analysis assessing outcomes of lung transplantation in a cohort of patients with AEILD, which is not limited to IPF. ये अब तो अभी तक जो known है उसमें first study है. The data reinforces the high short-term mortality of patients with AEILD, कि उनकी mortality वैसे ही high थी. Transplantation resulted in excellent and equivalent 1 year survival to those transplanted with stable disease, despite the high acuity of this patient population. And for retrospective studies, 4 retrospective studies, 3 जो हैं abstracts हैं जो कि publish नहीं हुए थे, और 1 published abstract have examined lung transplant outcome in ILD patients limited to those with IPF. इन्होंने भी ये देखा कि results were not comparable. जो AE-ILD वाले थे, AE-IPF वाले थे, उनमें survival बेहतर नहीं था with stable IPF. Modambi and Nair noted no difference in 30-day, 90-day, or 1 year post-transplant survival between patients with stable IPF and those transplanted with AE-IPF. On the other hand, OMIC found no significant difference in primary graft dysfunction, 30.8% in patients with AE-ILD versus 14.4% in stable patients, P 0.237. देखने में परसेंटेज काफी नजर आ रही है फर्क, लेकिन significantly जो है no difference है. और 1 year survival was not reported, although in that study of Tomic and colleagues. 28 patients with IPF transplanted during an AE had significantly worse 1 year and 3 year survival in comparison to those transplanted with stable disease, suggesting that lung transplantation in patients with the lung ये है lung allocation score जो USA में है, और इसमें scoring होती है 0 to 1, और इसमें ये देखते हैं कि age of the patient, otherwise fitness of the patient, and stability of the patient prior to this AE attack, performance status, distance from home वगैरह. तो इसमें जो score जितना ये actually priority का score है, LAS score USA में, और इसका 0 to 100 points होते हैं. Higher the points, the more is the probability, the priority for lung transplant. यानी ये patient जो है इनकी priority ज़्यादा होती है, तो इसका मतलब ये होगा कि fitness wise ये कम होते हैं. तो जो AILD वाले cases थे, suggesting that a lung transplantation in patient with LAS greater than 80 may not confer a survival benefit for these patients. यानी कि जिनका स्कोर जो है LAS स्कोर 80 से अबव है, उनमें सर्वाइवल बेनिफिट ज्यादा नहीं है. जाहिर है कि उनकी प्रायोरिटी लेवल ज्यादा है और वो ज्यादा अनस्टेबल हैं, तो इसलिए उनका जो सर्वाइवल रेट है वो कम होने का चांस है. Majority of these patients in our study were supported with high flow nasal cannula, unlike previous reports where a significant number received mechanical ventilation, extracorporeal life support, or both. तो एक ये भी डिफरेंस हो सकता है कि इनमें ज्यादातर को हाई फ्लो नेजल कैनुला पे रखा गया था, मैकेनिकल वेंटिलेशन और एक्मो सपोर्ट को पे इनको नहीं रखा गया था. तो दैट्स व्हाई ये रिजल्ट कंपैरेबल हो सकते हो. Patients in the cohort under discussion predominantly underwent bilateral lung transplantation, whereas those in prior report underwent only single lung transplantation. So this also be a factor. Majority of these patients were supported intraoperatively with veno-arterial ECMO. Previous studies reported 68% of bypass machine, heart and lung bypass use in patients with AIPF. Now there is growing evidence supporting utilization of intraoperative ECMO over both cardiopulmonary bypass or no support at all. So differences between our finding and prior experience may be due to recipient factors. Patients in our study were younger than those described in previous reports. Age group 60 plus minus 3 years versus 67 plus minus 5 years. So ये भी एक factor हो सकता है. Our findings support the use of a multidisciplinary approach to the care of these complex patients, in which pulmonologists, pathologists, thoracic surgeons, they should be sitting together daily rounds and then deciding the patient for appropriate for the lung transplantation. Close relationship between ILD and lung transplant physicians facilitates early referral of patients with AILD for transplant evaluation. In terms of post-transplant outcomes, although there was an increased frequency of primary graft dysfunction at the 0 hours in the AILD group, but there was no significant difference in severe primary graft dysfunction at 48 hours or 72 hours. And we report favorable early outcomes after lung transplantation in patients with AILD that is comparable to those with stable ILD, despite a significant higher LAS score in patient with AILD. इसमें बड़ी इंटरेस्टिंग बात यह है कि जो AILD ग्रुप था इसमें इनका LAS स्कोर भी 80 के करीब था, जबकि जो स्टेबल वाले थे उनका LAS स्कोर भी बेटर था, वो 42 पॉइंट समथिंग के नजदीक था. इसके बावजूद ये रिजल्ट्स कंपेरेबल हैं. We confirm that patients with AILD to have a high mortality when options are limited to medical management, reinforcing the survival benefit of lung transplantation in carefully selected patients in this setting. So this was all about this. Okay. The essence of it. It is a very large paper, and it was the essence which has been put on over here. So this was the whole description about it and the discussion points. So now it is open for any questions.
Okay, thank you, Azam. Very clear presentation. I think सब लोगों को जो है मैसेज जो है क्लियर चला गया इस पेपर का, और कोई ऐसा कंफ्यूजन नहीं था. और आप देख लें, अगर चैट बॉक्स में आप जाइए तो अब देखिए कि तकरीबन तमाम लोगों ने प्रेजेंटेशन को आपके अप्रिशिएट किया है. तो जो टेक होम मैसेज आपका यही है, जो शुरू में जैसे आपने कहा कि ये हम जो जनरली देखते हैं कि acute exacerbation of ILD, it has got a very high mortality. और अगर इनको हम ट्रांसप्लांट के लिए मतलब अगर फैसिलिटी हो, जाहिर है कि इनको भेजें, तो दे हैव गॉट ऑलमोस्ट सिमिलर सर्वाइवल कंपेयर टू स्टेबल ILD पेशेंट. दिस इज अ टेक होम मैसेज.
That's true.
तो अच्छा, बात यह है कि हमारे यहाँ मैं जस्ट अपना जो एक्सपीरियंस जो है मैं देख रहा हूँ इन द लास्ट 25-30 years, you know, the ILD has significantly increased. I tell you that when I joined AKU, we used to see one case every 2 to 3 months, and now in every clinic I see 3-4 ILD patients.
That's true.
और ये जो है क्या कहते हैं, बड़ा हमें इसके ऊपर रिसर्च करने की जरूरत है कि हम प्रिवेंशन के लिए क्या चीज कर सकते हैं. जाहिर है कि जेनेटिक फैक्टर इन्वॉल्व होते हैं, इट्स अ वेरी हेटेरोजेनस कंडीशन, लेकिन जेनेटिक के साथ साथ जाहिर है कि एनवायरमेंटल डज प्ले अ रोल. हम जो अपने इर्द गिर्द हमारे माहौल में जो एयर पोल्यूशन जो है, जो हम केमिकल्स मुख्तलिफ यूज कर रहे होते हैं, जो सब्जियों में इंसेक्टिसाइड वगैरह छिड़क रहे होते हैं लोग, तो ये सारी चीजें जो है वी नीड टू लुक एट कि क्या वजूहात हैं जिसकी वजह से ये जो है इतना रैपिडली इंटरस्टिशियल लंग डिजीज जो है हमारे मुल्क में जो है बढ़ रहा है. और न सिर्फ हमारे मुल्क में बल्कि इंडिया भी एक ऐसा कंट्री है जहाँ पे ILD जो है सिग्निफिकेंटली इंक्रीज है. और अभी जो जी आजम जी बोलिए.
One factor may be the birds fancier, बहुत ज्यादा हमारे इलाके में मुल्तान बहावलपुर में बहुत ज्यादा है क्रॉनिक HP. उसकी वो वजह है फंगस है दीवारों में बहुत ज्यादा. और अब शायद आगे सर पोस्ट कोविड फाइब्रोसिस, ऑल्दो वो एक अलग सेपरेट ग्रुप है, लेकिन उसमें भी बहुत ILD के केसेस देखने में आ रहे हैं, पोस्ट कोविड फाइब्रोसिस.
हाँ, सही कह रहे हैं. अब ये कि ये जो एक तो जो हमारे पास जो सबसे जो कॉमन है यहाँ पे, आप जैसे कहा कि HP सबसे ज्यादा कॉमन है जो कि हम अपने क्लिनिक में देखते हैं. अगर ILD हम सारे ग्रुप करें तो सबसे कॉमन ऑलमोस्ट 50% हमारे पास जो केसेस होते हैं वो हाइपर सेंसिटिव न्यूमोनाइटिस के होते हैं, और उनका क्लियर लिंक तो पिजन के साथ है. और एक चीज जो है लोगों में बताने की जरूरत है, जो कि भाई पिजन्स को जो लोग मतलब है कि दाना वगैरह डालते हैं मतलब अपने घरों में छतों में. अभी मैंने परसों मेरे पास एक पेशेंट थी क्लिनिक में जिसको HP था, और उसके हस्बैंड जो है वो छत के ऊपर जा करके रोजाना 5 किलो बाजरा जो है वो छत के ऊपर डालते हैं. तो वो आते हैं सारे पिजन्स, और फिर वो जो है ज़रा बालकनी के अंदर जो है वो ड्रॉपिंग्स होती हैं, तो उसकी वजह से ये होता है. तो समहाउ द अदर हम मतलब लोगों को बताने की जरूरत है कि भाई हम अगर कोई नेक काम करना चाहते हैं तो हम जो लोग बेचारे भूखे हैं उनको खिला दें. बर्ड्स का तो अल्लाह ताला ने वादा किया है, अल्लाह ताला बर्ड्स का रिस्क का इंतजाम कहीं ना कहीं से कर देता है, ठीक है ना. कोई बर्ड्स खाना स्टोर नहीं करता है, लेकिन जो हमारे और मुसलमान भाई हैं जो बहुत सारे भूखे हैं रमजान में इसमें, तो इस तरीके से भी मदद करके आप उनका सवाब कमा सकते हैं। और जरूरी नहीं है
या
कि हम
घर से दूर कहीं प्लाट में डाल दें कि वो चलो वहां एक जगह कंसंट्रेट हो जाएं, अगर शौक
हाँ
करना ही है।
हाँ, मगर ये कि चूंकि लोग डेंसली पॉपुलेटेड एरियाज में रहते हैं, वहाँ पे ऐसी कोई ओपन जगह जो है ऐसे मिलना जो है अक्सर बड़ा मुश्किल होती है लोगों के लिए। तो ये जो है इसको थोड़ा सा मतलब स्प्रेड करने की जरूरत है मैसेज हमारे। और सबसे कॉमन जो है हम लोग जो देख रहे हैं वो एचपी देख रहे हैं। तो आई थिंक अब मैं आपका शुक्रिया अदा करूंगा आजम, थैंक यू वेरी मच। आप आई एम
थैंक यू
श्योर
वेरी मच।
आप अभी हमारे साथ रहेंगे, दूसरे स्पीकर जो हैं हमारे वो प्रेजेंटेशन करेंगे। और आप अपना स्क्रीन अनशेयर कर दें तो मैं रिक्वेस्ट करता हूँ डॉक्टर मुजाहिद। डॉक्टर मुजाहिद चूँकि हमारे आगा खान के ट्रेनी हैं, he does not need much introduction. He is a very nice, humble gentleman, and we have seen his performance in hospital, nearly 5 years. And then after that, he joined Indus Hospital, and where he is working as consultant chest physician under Professor Sohail Akhtar. And he also does clinic at AKU as a non-full-time faculty. Dr. Mujahid is going to discuss with you another paper, and his topic is combining clinical, radiological, and genetic approaches to pneumothorax management. So pneumothorax is the topic that he is going to discuss. So I'll request Mujahid to share his screen and start his presentation.
सर स्क्रीन शेयर है? अस्सलाम वालेकुम सर।
हाँ, स्क्रीन तो शेयर हो रही है, आप फुल स्क्रीन कर दें, फुल स्क्रीन।
Assalamualaikum and Ramzan Mubarak, and thank you sir for the introduction. So I'll be presenting combining clinical, radiological, and genetic approaches to the pneumothorax management. As we know, since 2010, there is not much in the literature for pneumothorax. So I chose this topic to see that what's new in the pneumothorax. So that was published in February 2020 in second issue. So primary spontaneous pneumothorax affects around 1 in 10,000 people, with 10% having affected relatives, the so-called familial spontaneous pneumothorax. Appropriate investigations of familial spontaneous pneumothorax enables early diagnosis of serious monogenic disease and practice of precision of medicine, including the therapy of the underlying genetic disorder. Familial spontaneous pneumothorax comprises a diverse group of disorders with extrapulmonary manifestations ranging from renal cancer to arterial dissection, skin manifestation, and also body manifestations. A sizable group, around 73.6% of clinical unclassifiable familial spontaneous pneumothorax remains unclassifiable. Using whole genomic sequencing, the authors demonstrate that most of these cases are not non-monogenic disorders. As we know that a pneumothorax comes in, can cluster in families. So we know most of the pneumothoraces that are related to genetic syndromes like Bartter-Dube syndrome, Marfan syndrome, Ehlers-Danlos syndrome, TSC, LAMB, alpha-1 antitrypsin deficiencies. So pneumothorax genetic multidisciplinary team, which was formed, can efficiently diagnose a range of syndromic causes of familial spontaneous pneumothoraces. So they analyzed this cohort combined with additional whole genome sequencing data from 100,000 genomes project. So this project is basically going on in pneumothorax clinic in England. So they have started to see all the patients with pneumothorax who are referred to them. So to assess the efficacy of existing clinical radiological pathways for the diagnosis of familial spontaneous pneumothorax. So as I mentioned, that 100,000 genomic sequence project that was established in England in 2008. So between 2008 to 2020, 492 patients were recruited in this pneumothorax clinic. The familial cases were reviewed by a pneumothorax genetics multidisciplinary team, which comprised of respiratory physicians, geneticists, and thoracic radiologists. So each patient underwent a standardized clinical assessment to identify syndromic causes of pneumothorax, including detailed family history and physical examination. So, what they did, they initially the family history was taken, the history was taken, the examination was done, in history also the family history, first degree relatives, second degree, third degree, even fourth degree relatives were also questions and history taken. After this, the biodata, the arm span, the height, weight, all were taken. And then low dose CT chest was done. So the low dose CT chest was done in all recurrent pneumothoraces, all with family history of pneumothorax, thorax, and all female patients presenting with pneumothorax. So, and when the clinical feature suggestive of a syndromic cause, then the CT was also done. Then this was discussed in MDT meeting. So the data presented as absolute values, percentage, means, and standard error or median. Whole genome sequencing was performed on eligible participants within the 100,000 genomes project. These were some characteristics of those patients presented with pneumothorax. 492, majority were male with 379, and the median age was in males, in total it was 29, in males 27, in females it was 38. Family history was positive in around 14.6%. with 14% of males and 16% of females with pneumothorax. These are the height and weight, which are not that different from males and females. And BMI was around 20 to 21 in both males and females. Arm spans are also not that much different. Never smoker were 47%, that is 213 in number. And the tobacco user ever 151, that's 30%, and current were 79%. So and cannabis user there were also cannabis user, and some of them was having missing data in their smoking history. So recurrence in males, 130 patients was presented with recurrent pneumothorax, and most of them, around 70%, was on absolute size. So 5-year recurrence was noted to have 38.6%, which rose to 40% by 10 years of the pneumothorax, first pneumothorax occurrence. And 5-year recurrence of those 50 years or younger was 41%. 20.7% for those greater than 50 years, perhaps owing to higher mortality. I will later on discuss the mortality as well. And 39.3% at 5 years of greater than 5 year survival versus 1% for less than 50 years. The comparatively high overall recurrence rates seen in this series reflect the predominance of younger patients, as we will see later. 10-year recurrence was significantly higher in females, that was 63% versus 41% in males. with a p-value of 0.041. So when we saw results, so lymphangiomyomatosis was diagnosed in 2 women, which was 1.8%, while thoracic endometriosis, that is catamenial pneumothorax, was diagnosed in 9 patients, 7.9% of female cases. A positive family history of pneumothorax was elicited around 14.6%. Those of 492 patients that they were presented with pneumothorax, 14.6% patient presented with a positive family history. 14% of male and 16% were female. With slightly increasing female gender was associated with significant increase chances of recurrence as well. So overall 5-year familial spontaneous pneumothorax recurrence was 49% versus 36% in familial versus sporadic cases with a p-value of 0.036%. Bird-Hogg-Duke syndrome was the most common, accounting for around 47% of the genetic diagnosis and 2% of the all patient presented with pneumothorax. Alpha-1 antitrypsin deficiency and tuberous sclerosis were more uncommon, but they were around 5%. So this is the histogram of the patient with recurrence and no recurrence of pneumothorax. As you can see, then the age of those patients which are presented with a higher number of pneumothorax is around 20 to 40 or maybe 50%, 50 years of age, with this red showing the recurrence. So recurrence is also increased in the younger patients. So with no recurrence. And this the diagram B showing the Kaplan-Meier curve showing the proportion without recurrence. As you see in early months, like in early up to 12 to 15 months, the recurrence chance was high. Then later on, it becomes steady. Then other histogram on C showing the frequency of alive and dead patients with pneumothorax. As you can see, the younger patients, they were alive. Most of the, like the frequency of alive patients were increased, while those with the increasing age, they died more, which may be owing to their other comorbs and late presentation. In this Kaplan-Meier curve and D, it showed a proportion of alive less than 50 years of age and more than 50 years of age. As you can see, that this has a significant p-value of less than 0.001. Is most of the patient under the age of 50 years were alive, and the deaths were increasing more than 50 years of age. The male to female ratio, the histogram and the image E showing that the male were increased, the number of pneumothorax. There was a paper in genetics of pneumothorax by Boone et al. It showed that 1.7 to 1 ratio from male to female ratio. As you can see here as well, the pneumothorax occurring in male more than the females. And you can see in the other proportion without recurrence, male and female, you can see that the red line Kaplan-Meier curve in the figure F showing that female have the tendency, the pneumothorax have the tendency to recur. So they present with recurrent pneumothorax with a p-value of 0.017 as compared to male. So majority of the familial spontaneous pneumothorax, 73%, that is 33 individual, they fail to fulfill the diagnostic criteria of non-genetic disorder, because a patient comes, you see the patient, you examine the patient, the skin disorders, renal disorders, other. So there was around 33 individual, they did not fulfill the diagnostic criteria of genetic disorder. So these were recruited to 100,000 genome project, and different genome sequences was done, and they found that a single tire 1 variant identified in FLCN gene indicating Bardet syndrome, but with no features of no other features of Bardet syndrome. So, the tire 1 means the variant with approved course of clinical action. So there are other tire 2, tire 3, and tire 4 in genetics. They're mostly tire 2. You cannot do any other action based on this. And tire 3, they involve the malignancy. So of these, this patient, CT chest was done, which showed 2 cystic lesions. So these were the 33 patient which failed to fulfill the diagnostic criteria of the unknown genomic disorder, genomic syndrome. So of 33, male were 21, and the median age was around 29, with 24 in males, and females were a little bit older. And median age of first pneumothorax was around 21, and 24 males and 48 females. So ethnicity, most of them were white, with 2 blacks and 3 static. So these are the result of this 33 patient. Sporadic presentation of the pneumothorax were mostly present in these patients with some familial. And in B, Kaplan-Meier curve, you can see the sporadic, the proportion without recurrence. The familial with history of familial, they have more tendency to recur the pneumothorax. And this was the CT scan on D, which showed tire 1 variant of FLCN gene without any other Bardet presentation, but it showed a cyst. You can see the magnified image, a cyst in this as well. So overall, all the familial pneumothorax, majority, this pie chart showing a majority were Bardet syndrome, followed by Marfan syndrome, vascular Ehlers-Danlos syndrome, Loeys-Dietz syndrome. That's also a genetic disorder which present with vascular dissection, with pectus excavatum and other morphological features of hyperlaxity. TSC and alpha-1 antitrypsin deficiency were in less number in this cases. So in discussion, in this cohort of 492 patients with pneumothorax, 14.6 were familial, spontaneous pneumothorax, 26.4 were diagnosed clinically with a monogenetic genetic disorder, most commonly Bardet syndrome. There was a previous study in Chinese and European population suggested that up to 10% of pneumothoraces are due to FLCN gene mutation. In this cohort, the overall proportion was much less, around 2%. So this study is the first report of an association between familial spontaneous pneumothorax and increased chances of recurrence compared with the sporadic pneumothoraces. So as we saw, the female sex was associated with more increased chances of recurrence of the pneumothorax. So all genomic sequence of 33 individual, which we with unclassifiable familial spontaneous pneumothorax, as we already mentioned, the single tire variant indicating the clinical radiological assessment is a high sensitivity for non-familial spontaneous pneumothorax. So a previous genomic-wide association study reported an association between primary spontaneous pneumothorax and single nucleotide polymorphism, that is RS4733649 in the SLC6A1 gene. But this study failed to show in these 33 individuals with those cohort of normal without familial patients of 8,854 patients. So we cannot, this study cannot confirm this single nucleotide polymorphism as an association of familial pneumothorax. So COPD, as you know, that is the cause of secondary, major cause of secondary spontaneous pneumothorax, but deficiency of alpha-1 antitrypsin is its most common monogenic causes, but accounts for around 2% of the prevalent cases of familial pneumothorax. So this genomic wide association study has implicated other genes in COPD, like HHIA, IP, CHRNA5, HTR4, FAM13A, RIN3, and the other genes, but this study has failed to show any pathogenic variations in these genes in this study. So the conclusion was the assessment by a pneumothorax multidisciplinary team with geneticists has high sensitivity for diagnosis of monogenic causes of familial spontaneous pneumothorax. Enabling targeted genetic testing. This study, the authors find that familial spontaneous pneumothorax increases the risk of recurrence compared with sporadic pneumothorax. So a substantial proportion of the genetic risk for familial spontaneous pneumothorax remains unaccounted for, but this ongoing, as I already mentioned, 100,000 genomic data set that is going on is still, that's a piece of it, will address this as well. So, so those this is the maybe the last slide. This is the panel familial pneumothorax gene panel. So they have approved almost 10 genes till now, and they have put in they've called it green genes. They are checking in each patient presenting with familial pneumothorax. COL3A1, that is monoallelic, and Ehlers-Danlos loss vascular type में ये present होता है. FBN1 ये monoallelic है, autosomal Marfan syndrome में इसकी presentation. These OM1M, these are the number allotted by the panel to these genes. FLCN autosomal है, primary spontaneous pneumothorax जो कि हमने अभी देखा, but Duke syndrome के साथ भी present कर सकता है. And the other alpha-1 antitrypsin deficiency, Lloyd-Dietz syndrome, जो कि इसके तकरीबन 4-5 types हैं जो कि diagnose हो सकते हैं with this gene panel, and tuberous sclerosis 1 and 2 can also be diagnosed. So these are my two families, the Indus and the KUH family, with my consultant and Dr. Jaifan, Dr. Ali Zubairi, and Dr. Suhail Akhtar, and Dr. Saima Saeed. Thank you very much. Any questions?
Okay, thank you very much, Mujahid. तो टेक होम मैसेज आपने जो दिया वो ये कि न्यूमोथोरैक्स के जो हमारे पास केसेस आते हैं और जो उसमें फेमिलियल टाइप के हैं, जो हेरिडिटरी टाइप के हैं, नाउ वी हैव genetic testing panel available that can help us, beside clinical feature, that can help us in identifying कि ये कौन सा particular syndrome है.
जी सर. सर एक तो ये था कि इनकी जो स्टडी 100,000 जीनोमिक सीक्वेंस स्टडी थी, उसमें उन्होंने एवरी न्यूमोथोरैक्स को वो किया है, उनको इवैल्यूएट किया है. So they basically start with what the history is, then exam, and they exclude those they are already diagnosed genetic जो syndromes है, like कोई patient है जिसको पहले से ही Bardet syndrome diagnosed हुआ है और वो pneumothorax के साथ आता है, they exclude those. Then जिनकी कोई पहले से known genetic association नहीं है, they are doing what they are doing. They are उनको स्टडी करते हैं, इनकी हिस्ट्री लेते हैं, उनकी सीटी करते हैं. Then if the study and family history is very important. तो family history लेके फिर उनको जो है even they go into 4th degree relatives, so the vast इनकी history है. Then उसके बाद जो है वो decide करते हैं कि इसको geneticist के पास भेजने की जरूरत है या नहीं है. अगर नहीं है, like green genes तो उनके पास पहले से हैं, वो ग्रीन जीन्स को तो वो कर लेंगे इसको, लेकिन वो फिर जेनेटिसिस्ट के पास भेजेंगे, होल जीनोम सीक्वेंसिंग करेंगे. इन दिस सी के न्यूमोथोरैक्स वाले पेशेंट और कोहार्ट जो उनका नॉर्मल विदाउट फैमिली हिस्ट्री वाले न्यूमोथोरैक्स, उनमें क्या डिफरेंस है इन द जीन सीक्वेंस. इन दिस सी then they see the association कि ये कोई नई जीनोमिक यानी कोई न्यूक्लियोटाइड तो नहीं है उसमें. So they are doing it. They are not finished yet. उन्होंने एक piece of उससे वो किया है. And the take home message from my side would be कि हमारे पास बहुत से patients आते हैं, like अभी हमारे पास यहाँ इंडस में 2 brothers आए हुए थे, दोनों का recurrent pneumothorax, right sided pneumothorax and then contralateral next pneumothorax के साथ आए थे. 2 brothers हैं जिनका कोई clinically कोई हमें वो क्लू नहीं मिल रहा है. So ऐसे पेशेंट ये हो जाता है, मतलब ये अप्रूव हो जाता है पाकिस्तान में, इन फ्यूचर आ जाता है. So ऐसे पेशेंट को फिर हम इस तरह जेनोमिक स्टडीज करा सकते हैं.
अच्छा जी आजम, जी आजम,
वेरी गुड प्रेजेंटेशन और बड़ी इंटरेस्टिंग भी थी. एक चीज ये चीज थोड़ी सी इलेबोरेट करनी है कि ब्रिट हॉग जो है वो वैसे तो रेयर है, लेकिन जो ये जेनेटिक डिसऑर्डर्स आपने देखे तो उसमें कॉमनेस्ट ब्रिट हॉग था या वो किस तरह से ये. जी
सर, ये जो प्रेजेंट हुए थे विद न्यूमोथोरैक्स, उसमें उन्होंने जो इनकी फैमिलियल एसोसिएशंस देखी, उनमें सर ये कॉमनेस्ट था. जी सर.
अदरवाइज हम देखते हैं कि जनरली पॉपुलेशन में डिजीज वाइज इट्स वेरी रेयर.
यस सर, बिल्कुल सर.
हाँ, पॉपुलेशन में रेयर होता है लेकिन एग्जाम में कॉमन होता है.
जी सर.
हमारे एफसीपीएस पल्मोनोलॉजी के एग्जाम में these syndromes are often asked and जी. So Mujahid, in terms of a management, any difference between these pneumothorax with familial, is there any difference between two?
जी सर. जो 2019 में इसमें तो उन्होंने एलाबोरेट नहीं किया, लेकिन इसकी सप्लीमेंट्री उसमें भी है. 2019 में जेनेटिक्स ऑफ न्यूमोथोरैक्स जो ATS जर्नल में बून इट आल का था, उसमें भी काफी उन्होंने रेफरेंसेस के दिए हुए हैं. उसमें उन्होंने क्लियरली कहा है कि with a familial pneumothorax with expected increased chances of recurrence if you diagnose this, so you can go for early either CTS referral or for pleurodesis, chemical pleurodesis, for the prevention of the recurrent of this axillateral pneumothorax. एक तो ये इसकी मैनेजमेंट में चेंज होगा. यूजुअली हम फर्स्ट न्यूमोथोरैक्स में नहीं करते, लेकिन अगर हमें पता है कि फैमिलियल के साथ एसोसिएशन है तो हम फर्स्ट न्यूमोथोरैक्स में ही इसको प्लूरिडीज करेंगे, आइदर केमिकल और थोरेसिक सर्जन के पास रेफर करेंगे. एक तो ये. दूसरा जो सर है वो है उनकी जो सर्टेन केमिकल जो कीमोथेरेपी है फॉर सर्टेन डिजीजेस लाइक एफिल्सिन जीन एसोसिएटेड, उसमें भी कुछ mTOR इनहिबिटर्स, बाकी सारी जो है वो भी हम ऑफर कर सकते हैं अगर डायग्नोज हो जाए कि इसके साथ रिलेटेड है फैमिली.
चलिए ठीक है भाई. मैं चैट बॉक्स में देख रहा था, सवालात तो नहीं है, लेकिन एवरीबडी इज अप्रिशिएटिंग योर प्रेजेंटेशन एंड
वेरी गुड.
अनीता हैं, अब मोहम्मद इरफान हमारे हैं और एयाज अहमद हैं, एयाज अहमद जुनेजो, ये सब लोग आपको अप्रिशिएट कर रहे हैं. थैंक यू वेरी मच. और अगर और कोई सवाल नहीं है किसी के जहन में तो आई थिंक वी आर जस्ट अप्रोचिंग क्लोज टू द एंड. We have just 1 minute. So in the end, I just want to thank Azam Mushtaq from Bahawalpur Victoria Hospital and Dr. Mujahid from Indus Hospital. Both of them during Ramadan, it's often difficult to prepare presentation and then make presentation. So I'm most grateful to both of you for sparing time in Ramadan. एंड आखिर में सब लोगों का बहुत बहुत शुक्रिया जिन्होंने हमें ज्वाइन किया, और केजी फार्मास्यूटिकल का शुक्रिया. हमारी जो 2 यंग लेडीज़ हैं मिसबा और सादिया दोनों का शुक्रिया जो हमें हेल्प करती हैं इस मंथली थॉरेक्स का जर्नल एक्टिविटी के अंदर, और BMJ थॉरेक्स का शुक्रिया एंड केजी फार्मास्यूटिकल का शुक्रिया। बहुत बहुत शुक्रिया आप सब लोगों को, एक अच्छी
Thank you, sir.
अफ्तारी
Thank you, sir.
और पेशगी ईद मुबारक। इंशाल्लाह ईद के बाद आप सब लोगों से मुलाकात होगी इंशाल्लाह।
Inshallah, sir.
ओके
Thank
जी।
you, sir.
यहाँ पर लोकल यासिर बेग साहब हैं